Welcome. This is Megan Mitchell with Agents of Change Continuing Education. And today we have a very special guest who I have had the privilege to work with in my doctoral program. He is a classmate of mine, and he has so much depth of knowledge to bring to us regarding obsessive compulsive disorder, some of the evidence-based practices in that field, and really more information on where do we go from here. So Fran Kuhn is going to be joining us. He's an LCSW, he's a DSW candidate, and he does a variety of different things. He teaches, he also works in private practice, and he will tell us a little bit more about his journey in the clinical space. But we today are going to be continuing our clinical conversation series talking about OCD interventions in clinical practice. As you know, my name is Megan Mitchell. I'm not going to go through all of the different things that I do, but I work in private practice, working with children and teens. I mostly work with the neurodivergent population and a variety of different interests. I enjoy technology, I enjoy supervision and ethics, and of course, I enjoy working with children through play therapy and expressive therapy, and I am a current DSW student at SUNY Buffalo. Fran is an amazing clinician. He does a lot of work in his private practice around OCD. He is a advanced certified CBT clinician, and he really focuses in on the treatment of OCD. He's working with me in the DSW program at SUNY Buffalo, and there is a big emphasis on implementation sciences. He is very interested in training, consulting, and delivering evidence-based practices for clinicians. He has a variety of different experiences. He worked in schools for many, many years, so I am excited for him to talk a little bit more about what led him to this clinical specialty. Once again, here are our learning objectives. You can read them here. But the main thing I want to touch on is, why is this topic important? And I know that Fran will dive into this a little bit further, but a lot of clinicians may work with obsessive compulsive disorder or see symptomology that is in line with the diagnosis of obsessive compulsive disorder. But why is this topic important? Because we want to make sure that we're tailoring our interventions for our clients. So we are going to definitely talk about CBT, ERP, and then Fran's going to talk about some new evidence-based practices and some research coming out with iCBT. And why is this important? Because we want to make sure that we are giving effective interventions, evidence-based interventions with our clients. We are going to talk about equitable mental health access, why there are barriers to getting treatment to OCD, what inequities exist there, and how we can work towards advocating for systematic changes that will improve the access to quality care for all. And we will get into discussion about that. And then we are going to talk about the intersection of trauma and OCD and how we can be trauma informed in our work with clients that are experiencing OCD, understanding how our environment can be therapeutic, how it can be client-centered, how it can be trauma-informed, so that we can build that strong therapeutic alliance with our clients. So I am going to introduce Fran and sit back and enjoy this conversation about OCD interventions. Okay, I am very excited today to have one of my classmates in my doctoral program here, and someone that I think is an expert in the space on obsessive compulsive disorder. I have Fran Kuhn here today. He is going to share his knowledge with us and talk a little bit about one of, I know, his favorite topics, OCD interventions. So I will get to introducing him in just a moment, but I wanted to cover our learning objectives for today. So we have three main objectives. Participants will be able to understand evidence-based practices in OCD treatment. I know Fran's going to talk about what are some different modalities that you might use if you're treating obsessive compulsive disorder. We're going to get into a conversation about the inequities in access to mental health care, specifically for OCD treatment. and what might be some of those barriers. And then lastly, we're going to talk about the intersection of OCD diagnosis and trauma. I know this could be many, many different side conversations, but we'll hopefully get some time to touch on those big things. So I am so excited to have Fran here with us today. So Fran, welcome, and tell us a little bit about yourself, your background, and how you got landed in the OCD space.
Yeah, no, thank you, Megan. I really appreciate being here on your podcast, and thanks very much for inviting me along to have a chance to talk about all this important work. So I started my career as a school social worker, working in a high school, and I spent many, many years doing that. One of the things about school social work practice is that you tend to become a jack of all trades, right? That you have a lot of different variety of issues that you have to deal with or assess or help out with, but not enough depth with any of them to really become a master.
Yeah.
So there's quite a lot of exposure that you get. And over the years, one of the things that really intrigued me the most were adolescent cases that appeared to be related to obsessive compulsive disorder. And the first time it really broke through my awareness as something that A, I didn't know much about, and B, really wanted to figure out how to help was when I was working with a young man, a high schooler, who had become exceptionally terrified that he would become a zombie. And this was around the height of the very popular show, The Walking Dead. And this fear that was triggered within him grew and grew and grew. And this is really a nature of the illness that everything that becomes a trigger gets generalized very quickly, and people start to kind of vacuum up all these potential triggers that could lead them to their core fear, which is, for him, it was, what if I become a zombie if I'm exposed to anything? So his avoidance of things that were potential triggers got so severe that he really wasn't able to perform in school. And one of the first times I encountered him, he was attempting to climb a set of stairs without actually walking on the stairs because there was a fear that he would become contaminated with something that would turn him into a zombie. The wildly fascinating thing about this condition is that these are the folks who suffer with OCD tend to be highly intelligent, very creative, very rational, empathic, human beings who care deeply about things, who have this one area of their life where they are just wildly irrational in regards to their fear. So knowing that this was something that a lot of people that I was encountering had no idea about, did not know what to do with or how to assess or treat, it became a mission of mine to really figure it out. And the thing about school social work practice is that there's a lot of work to do in the day-to-day maintenance of the school and the students who are there, but not a lot of opportunities to do deep dives into certain topics around clinical practice. So over the years, I really had to kind of separate parts of my life from school social work practice to my own private clinical practice and teaching, where I'd be able to dedicate time and energy towards learning deeply how to treat various conditions that I was really interested in. So that sent me on a journey of really learning CBT in a very deep way, teaching that subject, becoming a diplomat in the Academy of Cognitive Therapy. And once I was in that world, the approach to treat OCD based on cognitive therapy principles started to become more clear. And as I started to see that there's a methodology that could be used to help people with this condition, I just moved right more in that direction, more training, more supervision, more workshops, more practice. And now my therapy practice that I've left the public schools to really dedicate my life more full time to this is about 75% individuals with OCD. And we're using a variety of approaches to treat the condition with the variety of successes you might imagine. But I want to couch this just sort of in a little bit of history for a second, that up until the 1970s, OCD was considered an untreatable condition. There's no method to treat it. We could talk some more about that, but this is relatively new territory in the field of mental health and psychology, and I think an excellent place for people who are really interested in this work to make a big difference, because the field is growing and changing and incorporating new knowledge all the time
Yeah,
up there.
I think those of us that do go into a niche area, we kind of have a story, right? Where this really, we maybe had a case or we had an interest. And then from there, it just starts to snowball into, okay, I want to learn more, 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 more. And I always say the longer I do this work, the more I know that what I don't know. So
Oh, yeah.
you could just keep learning and learning and learning. And like, that's what's so great about, I think, our roles as clinicians. You can always keep learning and developing. And we're going to talk about this a little bit specifically for OCD. The treatment and the evidence-based practices start to evolve too as we learn more. And I think, like you said, this being able to treat this condition is a newer concept. And, the 1970s is not that far off. So I'm sure there's a lot more research coming out around the condition, what is best practice. So we'll get into the why people might be a little bit hesitant to treat OCD, because I know that's a big thing that you see and the research shows. But so you get into this work. Tell us a little bit about how I know CBT is really your area of expertise, but how do you decide which evidence-based practice to use? Tell us a little bit about what exists out there that are kind of the gold standards for treating OCD.
Excellent. Yeah. Okay. Let's start with that. So the first breakthroughs that happened in figuring out how to treat this condition were by the behaviorists. These were folks that kind of as an intervention of last resort were working on operant conditioning principles. How do I get somebody to approach something that they'd rather avoid? And so a lot of positive reinforcement and behavior-based principles to treat the condition. And this was based on the idea that that patients with OCD were not doing any better at all using traditional talk therapy or certainly psychodynamic-oriented, insight-oriented therapies. The problem with OCD, as we now know, is that it's a problem of reasoning within the mind, and that asking people to go deeper into their mind to try to figure something out is actually worsening the condition. So the early treatments that actually had some effectiveness were behavior-based therapies that shaped people's behavior. They would avoid touching things that they thought were contaminated and could kill them or harm someone that they cared about. And so the therapy was, let's start to approach those things and touch those things. And the basic first idea was based in habituation. If I'm scared of something, I need to approach it again and again and again in order to get used to that fear, let the anxiety run its course, and then I'll become not so triggered by this event. So that's sort of intervention number one, was based on the habituation model. And that's been pretty successful for a condition that had no hope for it prior to about 50 years ago. And yet, even though the research results are pretty robust, only about 60% of people who are following this behavior-based habituation model called exposure with response prevention, only about 60% of those people really have lasting improvements. So like a lot of the transition in the field of therapy, psychotherapy, and social work practice, we've moved from the treatment isn't working because the patient is difficult to the treatment isn't working because we need to do a better job. And those newer waves of innovative practices that have come along in the past 20 years or so have, I think, really improved the basics of exposure with response prevention. So acceptance and commitment therapy has been a big addition to this. And those who are familiar know that the object of acceptance and commitment therapy is about cognitive diffusion. We want to separate from our thoughts. We're not challenging them in the way that a traditional CBT approach would ask us to do. So we're not doing thought disputation. We're not coming up with evidence against the idea that I could touch this doorknob and get AIDS and die or kill my family or something like that. What we're doing is recognizing that those are thoughts and those are experiences that we don't have to react to and get involved in. And that if we pivot to values-guided action along the ACT principles, then we can understand that we're having a thought experience, but that it doesn't have to command what we do. And
Mhm.
that if we do things, as in, I'm going to touch this doorknob so that I can open the door, so I can get into the room that I want to be in with the people that I love, then that becomes the motivator for the exposure part of the therapy. So by adding acceptance and commitment therapy principles, we're enhancing ERP by improving motivation to engage in the exposures. So I always liken this to, people with phobias, for example. And personally, I have a fear of heights, and at times I've struggled with driving over bridges, and that part of the worry is irrational, but the fear is compelling enough to say, well, maybe I won't drive over this bridge. But if there's family or loved ones on the other side, or a cool place to go to on the other side of the bridge, we use that as a motivative factor to say, if I'm going to live by my values, then that means I have to engage in this behavior so that I can not just overcome the fear or habituate to it, but that I can live a values guided life.
Yeah, I recent past year or so, I also started to dive a little bit deeper into ACT, and I think it's really fits well with CBT. And so I'm very prescriptive in what I do. It's everyone's going to need something different. I also work with young children, so I have used the SPACE model as well, which is a great model. For those of you that are not familiar, SPACE is it's a treatment model for OCD, severe anxiety, where it's parent focused. You might not ever even meet the child. It's a protocol, and it stands for supportive parenting for anxious childhood emotions, and that has been transformative for some of the work that I do. And it's basically exposure guided by the parents. So that has been really, really another treatment that's been really helpful. Sometimes I work just with the parents, sometimes I'll do both. So I think that what I'm trying to get at here is it's going to be a different approach probably for every single client based on what they need, their age, a variety of different factors.
You're absolutely right. And what you're kind of speaking to there is also a big picture point just about the condition of OCD. We know it now that it occurs in about 2% of the population worldwide. There's no distinction ethnically or racially in terms of how the condition presents itself. So it's really universal, but it's also considered one of the world's more disabling conditions.
Mhm.
And the reason behind that is because in your work, as you're seeing, that the person who's suffering from OCD often pulls family members and loved ones into their world, asking for help, for reassurance,
Mhm.
accommodations that the family members, because they love and care about their child so much, are more than willing to kind of step in and do for them. So the child who doesn't want to touch the doorknob, who has this contamination fear, is going to ask their parent or caregiver to do it for them. They're going to be so distressed and scared that the
Mhm.
caregiver is going to resonate with that and really want to help. And they kind of come to their emotional rescue, which makes all the sense in the world until we realize that that's actually making the OCD worse.
Yep.
So your approach with space is about really supporting the parents in reducing their accommodation behavior so
Mhm.
that they can separate what they're doing in terms of love for their child from helping the OCD. So you teach the parent to say, is that your OCD telling you that door handle is contaminated, or can we really tell that it's contaminated? And I'm not going to open that door for you because I don't want to help OCD. I do want to
Yep.
help you, right?
Mhm. It seems sometimes parents say, "Oh, it seems counterintuitive. What? I can't have my child be distressed." And I said, being distressed is part of the human experience. We all have to sit through distressing things. So a lot of times, you can share your experience. Is OCD, when you're treating it, one of those things that it might feel like it's getting worse before it gets better?
You in that standard exposure and response prevention approach, right? If you're looking at habituation as the goal, then logically speaking, you've got to get somebody to approach something that drives their anxiety up to a high level in order for them to get used to it. And actually, as the research shows, that the higher you can get that anxiety
Mhm.
level, the more change there is. So
Mm.
the more delta you get out of that, the better the treatment outcomes are. The problem is, try to ask an 8-year-old or even a 40-year-old to approach something that is terrifying to them. And the amount of work that you need to do that is quite high. So the, quote unquote, refractory cases or treatment resistant cases have been thought to be, problematic because the person is not sufficiently motivated to engage in exposures. And at some points, we sort of said, well, the therapist could do a better job, and here's ACT as a method to kind of enhance that, which is great. But we're still at the core of it with those approaches, asking someone to approach something that feels extremely scary for the purpose of getting used to it. And that's hard work.
It's, and I am very honest with clients about that. If we are starting exposure work, I've had clients tear up my office because the distress is, and they then afterwards, when the distress level came down, they said, "I'm so sorry." I said, "You don't need to apologize for anything."
Yeah.
Or I've been doing exposure work sometimes, and someone said, "You're such a bully." And I said that the OCD is being a bully right now. It's not me being a bully, but it can be, even as a clinician, it can be hard to sit with someone that's such in distress too, because I think our human nature is, oh, I don't want them to get to this distress level. But we know that getting them up to the distress level will help them build that tolerance to sit with the distressing thought. So it can be hard work, which leads me to the next question. Why do you think so many people avoid working with this condition? Or it can, I've heard some people, I don't, nope, that I do not treat OCD. I think for some people, it can be a little bit scary to engage in this work. However, it's important. I think as a clinician, someone's going to come into our office at some point or another that is experiencing this.
Without a doubt, right? And so that's another sort of mandate, I think, for all of us providers to be thoughtful about that. Even if it's not a condition you want to treat, it is our professional responsibility to become aware of it.
Mm-hmm.
And I emphasize that so much because it's such a problem in the field, just understanding how to recognize the condition. A lot
Right.
of people have sort of stereotypes in their mind about, well, OCD is only people who want to be perfectionistic or have everything in a certain order, or everyone's a little OCD, right? Or I'm a little OCD, or I went to Target and there's an OCD sweater that's right. So there's a trivialization around the condition, both in the media at times, and in our commercial spaces at times, that sort of misses the point in terms of just how disabling this can be, and distressing. And for the clinician who's unfamiliar, they're worried, and the survey research that we have out there really indicates their worry is that they're gonna cause harm. They think that their job is not to make people feel worse, right?
Right.
That their job is to make people feel better, uh, and that they don't feel confident in engaging in that exposure work. That they're scared to do things that they're asking their client to do, or they're scared to ask their client to do it. So a lot of clinicians will just sort of say, nope, as you pointed out, nope, I don't do this. And there's a tremendous lack of awareness. So, and one of the really alarming pieces of research that were done on primary care physicians who are given vignettes of individuals with OCD, the vast majority of primary care physicians missed the diagnosis. They did a little better, about half of them got it right when it was the most classic contamination-based fears, but about 80% of them got it wrong when it came to some of the more shameful and distressing experiences of OCD around fears of becoming a pedophile,
Yep.
fears of causing harm to others, fears of sexual assaults or violence. That the shame attached to those themes is a profound obstacle for people to even discuss
Yep.
what's happening for them. And when the physicians on the other side don't recognize it, we have this massive hole. And how do we even get people into treatment? Because their providers don't recognize what's happening to them.
Yeah, and I know you know the research much better than I do, but how often does it, I know there's a big time lapse before a lot of people actually get the diagnosis that's the correct diagnosis. So talk a little bit Do you think it is that lack of awareness, the maybe shame, and sometimes people don't even want to acknowledge that maybe this is the thoughts that are going on? Talk a little bit more about the misdiagnosis or missed diagnosis.
Sure, without a doubt, right? Especially in adults now, right? Like we're doing a little bit better in the pediatric population, as I'm sure you can attest to. But on average, there's a 17-year gap between when individuals begin to experience symptoms of OCD and if and when they ever get treatment. And the sad reality is the vast majority of people with OCD never get treatment.
Mm.
They suffer and create a burden of suffering for themselves and their families, and they're often kept secret, and it's a sad state of affairs. So the troubles start there, that there's not an emphasis on having to look for or assess for this condition. And I know we're going to talk about OCD and trauma a little bit, but as we learn a little bit more about trauma, it becomes even more important to learn how to assess for OCD, because there's a significant relationship between people with traumatic life experiences and the presentation of OCD as a condition, which we can talk some more about. But yeah, misdiagnosis is very common. People will be sent to therapists who are more traditional talk therapists, who are making things worse by offering reassurance, by telling people to just stop their thoughts, to wear a rubber band on their wrist and snap it whenever an intrusive thought happens. All really ineffective treatments. And so it's very common for people with a condition to experience a lot of treatment failures. And when they couple that with shame around the condition, it's alarming just how much of an obstacle that could be to accessing treatment. I did a little bit of a needs assessment with OCD sufferers, both in my practice and in the community. And there are two main themes that came out of that around what people felt they needed. And these are the OCD sufferers, that they needed to know that what they were experiencing was OCD. So even they did not know what was happening to them. And that contributes to the shame, right? Like all of a sudden, I'm terrified of this thing happening. I can't control the thoughts in my mind. I feel so ashamed or scared of it that I don't know what to do. And everyone I go and talk to about it, they don't know what's going on either. They tell me I should take a walk and do meditation or something like that. And that'll make everything better, and it doesn't. The more I try to figure it out, the worse it gets. I'm spending more and more time obsessing about things. I can't stop this behavior, and so on. It really snowballs. So there is a danger to not knowing what the condition is or how to treat it.
Something that I see, kind of going off of that, I have a lot of clients that feel very alone in this. Like they've been almost like they've been living with this secret. I've had some people say, this is a secret that I've never, and they've actually used the word secret. I've never told anyone about this. Like it can be scary to even go there mentally for a lot of our clients as well.
And there are unfortunately real world repercussions of this.
Yeah.
There are many stories of mothers, for example, who would tell their doctors in their postpartum state that they're having thoughts about hurting their child, and before they know it, the state authorities are intervening to do a safety assessment. So that there is a danger to that, and part of the recognition and part of the real treatment protocol now around OCD is that you've got to spend a lot of time doing psychoeducation, helping people understand what the condition is, how for them to recognize what's real and what's OCD. And you're right, it's often a very emotional moment where people feel a profound sense of being seen and heard for the first time in their lives, or since the first time they developed the condition. So you're doing amazing work there, Megan, for sure.
I never thought, oh, I'm going to go into clinical work and specialize. I'm definitely not specialized, but it comes across my practice much more than I would have thought. So even for me, that was an awareness moment. Oh, wow, I'm seeing this a lot more. Or I'll have people say, and they're super anxious, super, super, super anxious. And we unpack it. Yes, there's anxiety there, but we get to the root cause, and it is more in line with OCD than maybe like a generalized anxiety disorder. So I think that can be difficult too. It's like, and from you have a lot of expertise in this. How does a clinician know, is this extreme anxiety, or do we need to maybe consider obsessive compulsive disorder?
Yeah. Okay. So I mean, excellent points there, right? And why is it that OCD has been removed from the anxiety disorders, right? And
I was just looking at the DSM for refresher the other day, and it's not there anymore.
it's not there anymore. It's now considered under obsessive compulsive and related
Yep.
disorders. And there's an error with that. I think a critique that I agree with is that was the wrong thing to do, because what the framers and the folks that figured out where to move OCD really wanted to put it under conditions of repetitive behaviors. So trichotillomania or tic disorders or body focused repetitive behaviors of any kind. And the sort of repetitive compulsive behavior in OCD was how they sort of conceptualized that. But I don't think it's an accurate way of understanding the condition. It's not just about repetitive behaviors. So how do we start to get that feel for, like, oh, is this OCD versus generalized anxiety? The first part is that anxiety may not be the presenting emotion. In fact, shame and guilt might be, right? So we have to really broaden our definition of the psychological impact of OCD beyond fear, and that shame, guilt, and disgust are actually three key other emotions that we want to pay attention to. But the general nature, and we can start to see this pattern with a little bit of practice, is that for any individual with OCD, there's some sort of trigger, some event that has happened that is causing some anxiety that's related to a core fear. I'm worried about something happening. And that the method that they utilize to manage that fear is a behavior that may temporarily help with the intensity of that fear or shame or disgust, but then doesn't enough. And so that there's a doubting sequence that is almost like a trap door in the process that gets the person to feel anxious again, and then feel the need to engage in that behavior again for whatever it is. So I'll give you a quick example. You have somebody who has an OCD theme of what's called hit and run OCD. And the core question is, what if I, in driving my car, when I hit a bump or whatever, or didn't hit a bump, or just thought I hit a bump or something, what if I actually ran over a person and injured them? Mm-hmm. And that fear becomes so intense very quickly that the person is sort of scrambling for some certainty. What do I do to make sure that didn't happen?
I didn't do this, yep.
Right. So the natural sort of illogical but logical step from that is, well, I'm going to turn the car around and I'm going to drive and see if there's anybody there. Right. And even if I do that drive by and I've retraced my steps and I don't see any evidence that I've run over anybody, then folks without OCD are going to say that's a really silly thought, and I've got to get to work, and I'm not going to waste my time on this. But the person with OCD becomes so trapped by that fear or concern or disgust or shame that they feel so compelled to go and back and make sure that it's okay. So they're seeking certainty, where their brain will have them doubt it. So the OCD process is, you went back and looked, but you may have missed something. Maybe you should go back again. Or what if you missed something? Maybe you should contact the police and see whether or not anyone reported a hit and run. Maybe you should go to the police and turn yourself in just to make sure that you're not doing something really bad here. And what you might start to see underneath that is that there tends to be a core fear that the person has, not just about whether or not they ran someone over with their car, but whether or not they would be the kind of person who would be so irresponsible or so negligent or so indifferent in the wrong way that they could engage in an act like that. And that's going to get us a little bit into the inference-based therapy approach, but I think it's an insight that is really helping us understand the condition at a deeper level, that there are core fears that people have about who they worry that they could become, that are attached to various themes that their OCD takes advantage of, that keeps them locked in this cycle of there's a trigger, it's related to this deep fear, I've got to engage in a behavior to reduce it. I do that behavior, but then I doubt that I did it well enough or thoroughly enough or responsibly enough. And so now I've got to go back and do it again. And 3 hours later, the person's still driving around in circles looking
Right.
surety that they didn't hurt somebody.
And I think that's where ACT could really come in, right? That values base. What are your, what is this stopping you from doing? So now we're 3 hours in, right? And like, what has that taken from you, right? Like that could be now you're not able to get to a job on time, or that's time spent away from family members or a variety of different things. So I've done a lot of like values work with my older clients, of course. I can't do it so much with my younger kiddos. And quick question before we jump into like why is there these disparities and who gets care and all of that? Do you often see that a lot of times people have maybe like physical discomfort? Because I have some clients that, oh, I feel disgusting, like, and they're like, it's not that if I feel dirty, just some sensory thing within me is triggered and I cannot handle the way I feel. I've had someone say their muscles feel and everything in their body feels like it turns into noodles when they are not engaging in, it's a writing compulsion. So if they don't do the compulsion, they're like, I cannot handle it. And then they start to believe now my muscles are noodles.
Sure.
It starts to go into that. So is there a piece where some people might physically feel some discomfort or some something that then they're engaging in a compulsion to make that feel better?
For sure, right? So we think about this with the disgust-based OCD themes too, right? That there's quite a visceral physical
Yes,
reaction
visceral.
to these things. And so if we just think about it with anxiety for a second, the experience of anxiety is awful, right? And there's a reason behind that. I think as a lot of people know that it's a survival strategy. So if the fear center of your brain thinks this is dangerous and we should avoid it, it's going to make you feel so bad that you never forget that that was the thing that you should avoid, right? So we have to see it as like I'm having this powerful response because there's a part of my brain that's trying to keep me alive. And that to help people out, we help them see themselves as separate from that fear center of the brain, that they're the really executive in charge and they can override that with some practice. But that anxiety sensitivity is something that happens in a lot of people. I don't, it's not that I'm just afraid of this thing, I'm afraid of getting afraid. So anticipatory anxiety and then anticipatory anxiety. I don't want to be afraid of getting afraid.
Yeah.
And we're looking at, as you pointed out, the tolerance of discomfort or the tolerance of uncertainty. And where the habituation model, the earliest one in OCD treatment, was about get used to the fear in order to habituate to it, so your body kind of runs out of anxious energy. The ACT model is really saying whether or not your anxiety goes up or down isn't really the goal. It's not just about habituation. It's about, can you tolerate uncertainty? So can you do it scared? And can you do it because it matters to you?
Right.
So ACT has been transformative in I think, moving and evolving away from a traditional habituation-based model by saying we don't need to habituate so much. And it comes from the research, which have really found that some people habituate, but some people don't.
Right.
And that whether or not their felt sense of anxiety within an exposure session itself drops or not is not related to treatment outcomes. So there are people who may feel really anxious in a continuous way, but they're still going to recover from OCD because the thinking is at some point their rational mind is sort of learning that they are safe. And that gets into a small branch off of that tree called the inhibitory learning model of exposure therapy, which enhances beyond habituation to say, well, we're not just habituating, and we're not just tolerating uncertainty, but in addition to those things, we're inhibiting fear-based learning. So I do things, I do exposures because I need to learn that I'm safe. So I drive over the bridge to learn that it's safe to drive over bridges, not to just habituate to the fear and not to tolerate the uncertainty of whether or not the bridge is going to collapse. I do this to basically carve out more space in my life where I'm doing behaviors that create new learning for me. So if I'm afraid of contamination, a traditional habituation model would create an exposure hierarchy where somebody would, approach a doorknob, touch it with a glove on, remove one finger from the glove, touch it with that, and move up a stepwise ladder of exposures. The inhibitory learning model says, all right, on Monday, you're going to touch a doorknob. On Tuesday, you're going to lick your shoe. On Wednesday, you're going to hug someone with a cold. You're going to inhibit the fear learning in a variety of areas of your life. So not hierarchical, but like lifestyle wise.
Mm-hmm.
And that gels well with the ACT model because it has to do with values. Let's just go out there and live our life.
Yep.
Yeah.
This I think this will be a good segue. Tell me a little bit about the new, I don't want to say new, it's still CBT based, but kind of how you said we're combining different evidence-based practices here, but tell me a little bit about, I know for you it's exciting, some of the new treatment modalities or approaches, we can call it whatever, that are coming out around OCD and how this differs from the just plain ERP.
So this is let's say over the last 20 years or so, a fairly robust in terms of what the evidence shows, but rather unheard of approach in OCD treatment called inference-based cognitive therapy for OCD. So historically speaking, as we discussed, the breakthroughs in the treatment of OCD came from the behaviorist side of things. We just engage in different behavior and we create different learning through that process. We don't think our way through it, we do our way through it, right? And that's what exposure is all about. So many of the traditionally trained OCD therapists are very aligned with exposure therapy as their main method of intervention. And by the way, the CDC and the American Psychological Association both identify that exposure with response prevention is the gold standard treatment for OCD. So this is for good reason. ERP has kind of reigned supreme in terms of the preferred treatment approaches. But in a parallel way, the inference-based approach has been slowly gaining some traction and some evidence in the literature. And the studies that have been done by two individuals, Kieran O'Connor and Frederick Artema, over the last 20 years have essentially shown that the inference-based model is as effective, if not a little more effective than traditional ERP. And that a key reason for its enhanced effectiveness is that people are dropping out of treatment less. And the thought behind that is that inference-based models don't rely solely on exposure therapy as the key intervention. And this is where ICBT, I think, has a profoundly important evolution in the understanding of the condition. And I think is one of the reasons why I've really adopted it wholeheartedly in my own practice. So in the traditional habituation model, I'll try to explain this briefly, but of ERP for OCD, we have a trigger, we have a core fear that gets activated, and we have a compulsion that goes along with it. So a trigger is I need to touch a doorknob to get from here to there. The core fear is what if I become contaminated and hurt myself or someone else? And then the compulsion is wash my hands or get someone else to touch the doorknob or something like that. So the traditional exposure would say, touch the doorknob and don't wash your hands, right? So engage in the exposure without the compulsion. But you've got to get to the exposure first. Where inference-based cognitive therapy comes in is that it actually intervenes prior to the compulsion. It talks about the reasoning process that someone came to that allowed them to conclude illogically that there was a contaminant there. So we sort of pull it back earlier in the process to help people understand that the condition of OCD is not, an anxiety disorder. It's not, it's not a shame disorder. It's a disorder of cognition. It's a disorder of reasoning. So the fundamental principle is that people with OCD have experiences that bring them that are attached to things that are important to them enough that they're so concerned about not becoming the kind of person who could engage in certain behavior that they are trying to figure out how to make sure to not do that by reasoning in their mind and prioritizing a story that they might tell themselves about how things go wrong over reality sensing in the here and now. So we'll go back to that the idea of the doorknob, right? So the inference-based approach would say that the person with OCD approaches the doorknob and begins to tell themselves a story based on inferences and reasoning that is not totally illogical and doesn't come out of nowhere. It's actually attached to something that feels important to them. And if we could help them identify that, then the logic behind the OCD starts to make more sense. So, for example, this person might say, I'm approaching this doorknob and I have an idea in my mind that what if I touch this doorknob and I pick up a contaminant on this doorknob and I make myself sick or I make people I love sick in such a way that I become the kind of person who would be so irresponsible so as to make my family sick. And that if I'm really that kind of person, then I'm not the person I want to be. I am not the person I hope to be in this world. And that is so terrifying to me that I am now involved in what's called the OCD bubble, a whole story about what I did wrong, what I could do wrong, what will go wrong as a result of me touching this doorknob. So when we help people understand that that's their fear that they experience is a result of the reasoning process that they're going through, then we could help them differentiate that reasoning process from the ways in which they reason about things that are not related to their core fear. So, for example, people with contamination-based OCD may not have hit and run based OCD themes, right? So you can help them by pointing out, well, how does the person who has a hit and run theme become inferentially confused? How do they cross a bridge between reality sensing here in the moment, using their five senses to figure out what's going on? I'm driving the car, I'm looking at the road, I'm hearing the traffic, I'm feeling the vibrations. And that's my sense making data. And then I have this crossover point. I hit a bump and I ask myself a what if question. What if I ran someone over? And that's based on that person's core worry that they'd be the kind of person who would be so irresponsible and so on, so as to do that. So when folks with OCD can see how other themes that are not their own and don't trigger them are illogical and are a function of inferential confusion, they can begin to apply that learning back to themselves and identify a crossover point, often the what if question. So I close the door, I turn the lock and I'm staring at it, but what if I didn't do it perfectly well? What if that means that somebody will break into the house? What if that means I'm the kind of person who would be so irresponsible as to let that happen? When I'm stuck in the story in my head, I'm prioritizing that story over reality. And if I can trust my senses, I can trust what my eyes see. I know I turned the lock into position. I'm gonna choose to trust those senses, recognizing that I could easily cross over into this obsessional story, but if I trust myself, then I don't need it. Therefore, we don't need to do exposures in this traditional way, or like unlock and lock the door and just get used to the fear of that. we can do exposures, or actually what we'll do is more response prevention,
Mm.
but it's based on, we're going to choose to trust ourselves. So I'm going to drive in this car, I'm going to drive at night, I'm going to drive in the rain, I'm going to drive and I'm going to hit a bump. And that's my sort of exposure. But what I'm really going for is to not engage in the compulsion of doubling back and checking, not because I need to do that to habituate to the fear, but because if I choose to focus on my senses and trust those senses, then I don't need the fear. So OCD is thought to occur 100% in the imagination.
Mhm.
And if we can interrupt the process earlier on by saying that's an OCD story about something that's never happened and isn't happening right now, and there's no need for me to take any action about it right now, then I don't need to set up an exposure hierarchy. I don't even need to feel this anxiety right now. And so if I can trust my senses, then I'll habituate to the anxiety, but it won't be because I'm exposing myself. It's because I'm trusting myself.
Mm. I'm taking the training on this in a couple weeks here, so I'm very excited because I have some clients that are so intellectual. They're very, very, very bright. And I actually think this model is going to work better for them because they're so up here in the cognition space that it can be, the exposure is not enough or it's not the right treatment for them. So I'm excited about learning more about this.
I'm happy for you, and I hope that explanation made sense.
It did.
I think what we're seeing, and again, those traditional exposure exercises, is that people will do a lot of safety behaviors that kind of undermine their undermine the intensity of their exposure. So someone will say, well, I did touch that doorknob, but I had my fingers crossed behind my back, and that's my thing that that warded off all the evil that could happen. So when we get people to just engage in the behavior without engaging their mind, or their thought process, they can escape a little bit or avoid a little bit, even in hidden ways.
Yeah.
And so a lot of traditional ERP therapists focus on kind of a cat and mouse type game where they're pulling out or trying to figure out if somebody's doing safety behaviors during exposures. That feels, for me, not an ideal approach. And the inference-based approach, where we're getting people to trust themselves, I think is so profound because logically it kind of pulls the mask off of what OCD is and helps people understand it, but it also returns agency and power back to the individual sufferer. And I think that's a trauma-informed thing to do
Yeah.
too.
And I think that's a good segue. Then the last two things we're going to talk about, I think, go together. So there's a lot of inequities in who is getting care for this. And there's a big overlap between trauma and OCD diagnosis. In that, I mean, I'm not an expert in this area, but those I've talked to that work specifically with trauma said they can definitely come to play together and the OCD behaviors become worse if there is a trigger from the past trauma. So I know that we talk a lot about trauma-informed care in our program. That is a big lens that we look at things through. So tell me a little bit about how trauma plays into OCD and why you think there are these barriers that people are not even getting proper diagnosis, or they're also, we know there's barriers that a lot of times people are paying out of pocket for clinical services too. So I'll open that up to let you take that however you want.
No, I appreciate that. Right. And I think there's strong opinions on the question of access to treatment and who's paying for it, and how it gets reimbursed and so on, that, I could try to address a little bit here. If we start with the question of trauma, one of the insights that we've discovered over the last 10 years or so is that there's quite a substantial relationship between people who have had traumatic life experiences and the degree to which they would develop OCD symptoms. So where OCD occurs in about 2% of the population worldwide, for people with traumatic life events, that number jumps to about 30%.
Wow.
So it's a huge increase in the presentation of OCD among trauma survivors. We don't know at all, really, the exact mechanism as to how that happens. I think one of the key ideas that's still being tested is whether or not the symptoms of OCD are a coping strategy for
Mm,
people with trauma. So in one specific example, you would look at somebody who has experienced a sexual assault. That's a trauma. And as a function of that sexual assault, they now have developed contamination fears related to OCD. Uh, and so we can sort of see how those things would fit together. So that's sort of one idea about it. But there's also, I think, an important point when you ask OCD sufferers themselves whether or not they think that the experience of OCD they had was traumatic. Most folks say yes. And it's not just because we throw the word trauma around all the time, although that's, I think, part of it. We need a clearer definition of trauma. It's for these people that they understand that this condition has profoundly impacted them, has caused tremendous fear, has taken them away from things that they love, has maybe eaten up years of their life. And that feels traumatic for people. But the only definition that we have diagnostically for trauma is PTSD.
yep.
And in that way, the experience of OCD doesn't quite meet the diagnostic criteria for PTSD. There's some overlap, but what it really tells us, I think, is that we need a wider definition of trauma
Yep.
and how that shows up to incorporate the lived experience of OCD sufferers. Um, how do we treat trauma in OCD? Well, it's tough because there's sometimes a relationship between the trauma triggers and the OCD triggers that needs to be pulled out and treated individually. So somebody might have a flashback to their sexual
Yep.
assault that will create a trigger for them to engage in their hand washing compulsions. We have to help people understand why they're having this traumatic response and help them understand why they're having the OCD response. And if we could treat the trauma response, sometimes the OCD symptoms take off and become more intense, and it's a little bit of whack-a-mole.
Okay.
But over time, as individuals learn how to manage their trauma response to things through the prolonged exposure, perhaps, or even better, cognitive processing therapy,
Mm-hmm.
or what's coming online as a more evidence-based practice for trauma in EMDR, if we can kind of help the person incorporate the traumatic experience into a personal narrative that helps them uh, move beyond the being stuck on the traumatic experience, then we could also help them manage their compulsive behavior in light of trauma-based triggers. But the real protocols of treatment have not been fully fleshed out. This is still an area where there's a lot of development involved, where we need a lot of case study data to help us understand what works and doesn't. And it's an exciting area of practice because there are people who are walking around who are really in pain, who aren't getting the care that they need.
Two questions for you. So I know that we talked previously about a lot of times it's not trusting our sense of self, right? With someone that does have maybe a traumatic event and there is not a lot of trust, what do we do there? Because I've had some clients that they can't trust themselves because they've had a trauma that has diminished that sense of trust in anything.
Without a doubt, right? So the trauma itself is so profound because it violates the just world hypothesis. I'm supposed to be safe, things are safe, this is all right. If I'm a good person, if I do the right things, bad things won't happen to me. And that, especially in the shame-based traumas like a sexual assault or something like that, it's very easy for the person to conclude that there's something wrong with them. And so we really need to do good cognitive behavioral work on that. And I think cognitive processing therapy is a great fit because it helps people understand that they are not their trauma.
Right.
So we'll go back to Bruce Perry here,
Yep.
what happened to you versus what's wrong with you
Right.
as a key distinction to make to help people see themselves as complete people with areas of interest, strengths, challenges, and whatever in light of the trauma that they've had, not in spite of it, and not that they are their trauma. So post-traumatic growth, I think, has a big role to play here, and I focus a lot on that. Yes, trauma happened to you, and let's grow. Let's keep going. And that, the OCD part of it means that we have to see that the OCD in some ways is trying to protect us.
Yep.
It's giving us a way of managing the trauma that we have had to rely on because we haven't been able to process it in a therapeutic way.
And then my second question is, I've had a few clients that have trauma, like absolutely meet the criteria for PTSD, but for them, it's easier to chew off, I have OCD versus PTSD.
Mm-hmm.
So in those cases, like, where do you start? Do you start with OCD? Do you start with the PTSD? Or is that just a lot of like using your clinical judgment and seeking consultation? And where do we go when we have those really tough cases?
Yeah, right. Yeah, I mean, getting involved in the communities that are out there is really helpful. There are some really robust Facebook groups of clinicians who are treating these conditions that are in regular communication and offer consultation and trainings and feedback and support. So I think, get involved in your network, develop your PCN, your professional collaboration network, right? We need that because there isn't a manual for this yet, that just hasn't been developed. So we need to talk to each other. We need to talk to our clients. Often it comes down to what feels most important for them to get out of their way in their life. So someone I had treated this past summer had very strong disgust-based reactions to things in their home that they had small children, and so feces, vomit, germs of different kinds, very disgust-based reactions to these things that were housed and related to an earlier childhood trauma that they had experienced. And so what we needed to focus on was the fact that there was this early trauma that needed to be processed. But in the here and now, what this person really needed to do was be able to change their kid's diaper. So we had to focus on the exposure part so that they could get back to some functioning and to learn that, yes, these are triggers for your trauma, but we need to get the exposure work done, and then we could work on the trauma. And in other cases, we work on the trauma and then do the exposures. So it's whatever makes sense to the individual. And sorry, I'm getting blown away by the sun here.
It is fine.
Yeah. So it's whatever makes sense to the individual and what their priority is too. And as usual, we want to be collaborative and client-centered in all this.
Yeah. And I think that leaves me with my last question, to shine your advice. So say someone, I mean, I think everyone should have some knowledge, right? So at least some sort of basic knowledge of what this is. But let's say our newer clinicians, or maybe people are still in grad school, and I can tell you I did not learn specifics about this. I took probably a very basic CBT course in my graduate program. What should a newer clinician or someone that wants to go into clinical work and, is like wanting to learn more about this and just start from the basics, what do you suggest?
Right. So I want to weave in there a little bit about the inequities in this too, because it's really important, right? And it'll speak to that because there are no graduate programs in social work practice that prepare people to treat these conditions. Maybe you'll get it if you wind up in like a postdoc, PhD or clinical psychology program, if you're lucky enough to wind up at one of the major hospitals or clinics that are out there that are kind of the expert centers for treating these conditions. It's very difficult for clinicians in community-based practice or private practice to access the trainings and supervision and consultation that they would need in order to learn how to treat these conditions. And the reality is that the insurance companies don't reimburse clinicians who have invested in additional training or supervision in order to offset the cost of those things. So there's a disincentive for clinicians to even learn how to treat these things. So that limits access to care. And it also leaves, the only purveyors of access to care as insurance companies whose incentives are not aligned necessarily with client outcomes. And some recent studies on this have indicated that one of the problems has to do with the federal government's not um, increasing reimbursement for the treatment of these conditions through their Medicare or Medicaid programs. And so the private insurers are waiting for the public insurers to prioritize uh, treating these conditions in a way that would actually reimburse clinicians who are seeking training and supervision and how to learn how to treat this. So it's a perverse incentive system and it's unfair. And I think some of the workarounds involve people saying, I'm just not going to work with insurance companies, and I'd rather charge someone $20 for a session that they can afford, where I can actually work with them and deliver treatment that I know works, than deal with the rigmarole of an insurance provider who doesn't really understand what I'm doing, or the different approaches or intensity of sessions that I need to have, or the lengthy sessions I need to have, or the parent consultation that I have to do. None of those things tend to be reimbursed by insurance companies. So it's a failure that impacts clients, and that's a tragedy. But the therapists are often the ones caught in the middle, not the ones who are really perpetrating these inequities. So I want to start by saying that for newer clinicians, we need you. We need lots more people who know how to treat these conditions. So if you're interested in this, let me tell you, it is a fascinating role to get involved in, and helping people, as I'm sure you know, Megan, helping people develop the insights that they need to understand what's happening to them, to understand that they're not alone, to understand that what they're experiencing is a treatable mental health condition, is just profound work that we can do.
Mhm.
It's super rewarding. So I promise a life of high degree of interest and high reward if you want to get into this. The challenge then is, how do you go and get yourself the right training? And for
Right.
newer clinicians working in institutions, community mental health agencies, really think about asking for help to pay for training and supervision and consultation to treat this condition. The International OCD Foundation is the really world leader uh, in sharing and disseminating evidence-based practice, research findings, advocacy. They've run several annual conferences, and they provide training to treat OCD through a wing of their organization called the Behavior Therapy Training Institute. It's a very expensive training, unfortunately, but if you can get your employer to pay for it, and through this demonstrated need, then that's a good direction to go.
And I believe it was through the Behavior Institute. You can sometimes find, if you treat specific populations, they might give like discounted, or there are some ways out there to get some discounted trainings. I will just put this out there. I have found, so Fran and I are both in a doctoral program. I have found they sometimes give student discounts, or ask. What's the worst they can say is no, right? Like, do you have a scholarship, or do you have some sort of sliding scale for this? And some people will give it and some others won't, but there are opportunities out there to offset some of these very, 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 very expensive costs of training. It's like one of those degrees, right? It never stops with the learning that you need to do, and that's a barrier, right? Money is a barrier sometimes.
It for sure is, right? Now, I've ushered at conferences to get the free attendance, right? So I'll show people to their seats and tell them what ballroom to go to, as long as I get to go in with them and take
Right.
furious notes in the back of the room. So we've all had to scramble at different points, but part of the other advocacy is to say to our government leaders and the leaders of private insurers, public insurers, that they really need to enhance reimbursement for the efforts that go into treating these very challenging conditions, and that just an MSW is not going to be sufficient to help with this.
Yeah, absolutely. Well, I feel like we really got the expert in the room here to talk about this. So thank you, thank you, thank you, Fran. I have put some different citations of some of the research I pulled. As you can see, it's all newer here. So if people want to check that out,
Oh,
Fran and I have to do a lot of research and finding quality evidence-based articles. So this has been another fun thing for me.
oh.
And then, of course, Fran, I want to thank you for sharing your expertise, sharing your time. And I have a feeling we can go down a lot of other rabbit holes for some other topics around this as well. I mean, we could talk for 5 hours about this.
I think so, right? It's a robust field, and I appreciate your very conscientious questions here, Megan. And I know it's an area that you have a lot of interest in too. So I'm so glad we were able to have this conversation. And for anyone who watches, if
Yeah.
this feels informative, then great. Really thrilled.
Yeah. That's what I was thinking when we're like, what advice? This is step one, right? If you're listening to this, like hopefully we're sparking some interest here and you're maybe gonna take the next step to learn a little bit more.
Absolutely. Follow your instincts, follow your interest. It's a robust field, and you probably can't go wrong.
Yeah. Well, thank you, Fran, and thank you for your time.
Thanks so much, Megan.
Thank you. I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.